Hello, and welcome to the latest episode of our psoriatic arthritis podcast series. Alongside our RA and axSpA podcast, we'll be bringing you monthly slide decks to help keep you up to date with the latest research and publications in the field of psoriatic arthritis. I'm Dr. Philip Mease, Director of Rheumatology Research at the Providence Swedish Medical Center and clinical professor at the University of Washington School of Medicine in Seattle. Joining me today is Professor Laura Coates from the University of Oxford's Nuffield Department of Orthopedics, Rheumatology, and Musculoskeletal Science. Today's discussion will focus on two papers. The first is a study that used real-world data to analyze biologic switching in psoriatic arthritis. And the second involves the development of extramusculoskeletal manifestations in upadacitinib-treated patients with psoriatic arthritis or axial spondyloarthritis. So over to you, Laura.
Thanks, Philip. So today's first author is authored by Haddad et al., and it's looking at biologic switching in psoriatic arthritis, insights from real-world data and key risk factors. So obviously we know that psoriatic arthritis is a very variable inflammatory disease. We use quite a lot of different targeted treatments, and we select them based on a lot of different factors: the clinical manifestations, the disease severity, related conditions and comorbidities, and other patient-specific factors. And a lot of therapies will work for a time, but then lose response. So we often switch through multiple targeted therapies for patients under our care in the long term. So what this paper wanted to do was look more at the switching patterns in psoriatic arthritis to understand a bit about how our practice looks in the real world at clinics and how that's changed over time, because obviously in the last 10 to 20 years, we've had a big increase in therapeutic options, and that's had an influence on how we think about choosing therapies. And obviously, we have changing data all the time, new therapies coming through, new data on old therapies, data on longevity of drugs, for example. And there are other things that obviously play into this around access to therapy. So depending on your healthcare setting, there may be some drugs that are restricted access, some drugs that you should use first line, for example, because of cost-related factors. So if we can understand a bit more about what happens in switching biologics, we can think about what normal treatment strategies might look like and how we might optimize those. So this study really looked at the switching patterns of biologic use in patients who had PsA and thinking about predictors of how those decisions were made. So this is a retrospective cohort study, and it's using health services database, so kind of claims data basically, and looked at nearly 10,000 psoriatic arthritis patients under treatment in Israel. Patients were initiating biologics. Around a third or just over of the cohort were then tracked for therapy switches. And they looked at all of the key targeted therapy groups. So TNF inhibitors, IL-12/23, IL-17, IL-23, and then JAK inhibitors as well in the targeted oral space. They looked at what clinical data they had around the psoriatic arthritis, the demographic data and the socioeconomic data for these patients, and then looked in the analysis at characteristics between switchers and non-switchers. And obviously, I mentioned how much our access to drugs have changed over the last 10 years or so. So they actually grouped patients into two different time periods, 2005 to 2014. And then 2015 to 2023, because over those time periods, we had very different access to therapy. So among their patients who were initiating biologic DMARDs, that was 3,851. 48% of them had a switch in therapy at least once, often multiple times. And patients who switched when compared to those who did not switch were more likely to be female, more likely to be obese, more likely to be smokers, and more likely to come from lower socioeconomic backgrounds when compared to those who were not switchers. In both of those different time periods, TNF therapies were the dominant first-line choice. Obviously, they've been around for the longest time, and now in many healthcare settings are the cheapest option. So I think that makes sense. Initially, there weren't many alternatives. Then when we looked at the first switch, so the second targeted therapy, the most prevalent group of drugs were the IL-17 inhibitors. And then beyond that, subsequent switches were more variable. So some cycled back to a different TNF inhibitor, having had that first line, and some transitioned to the newer mode of action like IL-23 inhibitors or the JAK inhibitors. And there was some consistency around that switching period across the study periods, although obviously, access to some drugs like IL-23 inhibitors was only in the later time period, and they weren't available in the first time period. So I think this study shows and certainly matches, I think, with what we see in clinic, that cross-class biologic switching is pretty common when we're managing patients with PsA, and it's influenced by quite a few known patient demographics and comorbidities like obesity and sex differences. The switching patterns were generally pretty consistent despite expanding therapeutic options. I think that's probably quite different to what we would see in dermatology, for example. And these results really highlight the changes in biologic therapy use and the amount of switching that's happening and how that's influenced by access to therapy, patient characteristics, and maybe changing evidence around treatment strategies.
Thanks very much, Laura. This is a very interesting set of findings. It is consistent with some of the findings that we've found in the core Evitas registry in the U.S. and I suspect several of the European registries that you're familiar with. One of the things that we have found when we've split the switching analysis according to a set of years is that in more recent years, we find switching to be a little bit more frequent than, say, back in the mid-2000s. And part of that is simply because I think physicians and patients know that they have more drugs to choose between. And I think they're a little greedier to get to a state of optimal disease improvement. So, for example, we're using the clinical criteria that you developed, the minimal disease activity criteria. And if the patient, just imagine a patient in Seattle, very tech savvy, coming in with their spreadsheet, wondering which of the items of the MDA have I achieved or not achieved. And if they haven't, then everybody's restless. They want to get to a state of better disease activity, and so we find, at least in our clinic, a little bit more frequent switching, and we found that in the core Evitas registry as well. And in our situation, we're now up to our third, fourth, or fifth switch, and obviously, that's going to involve more of the newer type mechanisms of action as well. How is it in the UK? I know that you have a little bit more restrictiveness than we do in the States.
Yes, I think it varies across Europe and even within the UK in terms of access to therapies. We very much routinely use first-line biosimilars, so that would fit with this data showing TNF first line. And obviously for peripheral arthritis, we don't have any drugs that have been shown to be superior to that. So while you might argue for a different drug for patients with bad skin disease, actually for the predominant kind of peripheral arthritis, then I think biosimilar TNF is a perfectly reasonable first-line option. I think, like in this study, we would typically use IL-17's second line for a lot of our patients with the good head-to-head data as well. The access to therapies is variable, even certainly across Europe, but even within the UK. So our particular region is restricted on number of switches, and so that makes us a little less keen to switch, and a bit more keen to try and optimize other things around the biologic. So maybe that's adding in methotrexate, or working with physiotherapy, or injecting joints, or thinking about pain management and other things on top to try and kind of get the best out of any biologic therapy that we're using. So that definitely influences the way we switch, and the amount we switch. But I think this pattern of switching very much kind of fits with what you would probably see in a similar UK data set.
Which is lead authored by Dennis Podubny, entitled Development of Extramusculoskeletal Manifestations in Upadacitinib-Treated Patients with Psoriatic Arthritis or Axial Spondyloarthritis. Extramusculoskeletal manifestations, or EMMs, for these diseases include uveitis, inflammatory bowel disease, and psoriasis. Of course, psoriasis is typically part of psoriatic arthritis and is present in up to 10% of patients with spondyloarthritis. The presence of these EMMs is often associated with higher disease activity, greater functional impairment, and substantial economic burden. And of course, we know that these conditions are a bit more frequent in psoriatic arthritis and axial SpA, partly because of genetic patterns that contribute to the evolution of these appearing. Upadacitinib has demonstrated efficacy for the treatment of PsA, radiographic axSpA, and non-radiographic axSpA. However, there are limited data on the impact of JAK inhibitors like upadacitinib on the development of EMMs in patients with spondyloarthritis. For example, one of the concerns that we might have with use of IL-17s, for example, is will a patient who has a background history of IBD have a greater chance of having a flare of IBD during the course of observation in a clinical trial or during treatment. So this post-hoc analysis assessed the development of EMMs among patients with PsA or axSpA treated with upadacitinib 15 milligrams, placebo, or the active comparator adalimumab in the select clinical trials. EMMs, including uveitis, inflammatory bowel disease, and psoriasis, were captured as part of the patient's general medical history at baseline and were reported as treatment-emergent adverse events during the study. These events of EMMs were analyzed using data from 5 clinical trials, 2 in PsA, 2 in radiographic axSpA, and 1 in non-radiographic axSpA, observed up through August 2022. As psoriasis is considered a core domain of PsA, it was only evaluated as an EMM in radiographic axSpA and non-radiographic axSpA trials. So what was seen? The majority of patients, between 87% and 99%, did not report a history of EMMs at baseline, regardless of disease indication or study treatment. Regarding the development of uveitis in psoriatic arthritis, this development was quite low, regardless of treatment or prior EMM history. In radiographic axSpA and non-radiographic axSpA, the development of uveitis was seen to be numerically lower in patients treated with 15 milligrams of upadacitinib versus placebo. In terms of the development of inflammatory bowel disease, this was absent or low regardless of treatment or prior EMM history across all 3 conditions here: psoriatic arthritis, radiographic axSpA, and non-radiographic axSpA. If we turn to development of psoriasis in the axSpA trials, in radiographic axSpA, Psoriasis was quite infrequent in patients treated with placebo or upadacitinib, and in non-radiographic axSpA, no events of psoriasis were reported. If we look at the EMM subtype, focusing first on anterior uveitis, this was the most frequently reported uveitis subtype across all indications in patients receiving 15 milligrams of upadacitinib. And as mentioned, it was quite low and numerically lower than in placebo. The most frequent IBD subtypes were Crohn's disease and ulcerative colitis, both PsA and radiographic axSpA, and ulcerative colitis in non-radiographic axSpA. Overall, these data suggested no apparent increased risk of developing EMMs with 15 milligrams of upadacitinib therapy. I'm going to say that over again. Overall, these data suggested no apparent increased risk of developing EMMs with 15 milligrams of upadacitinib therapy, which is reassuring. The development of EMMs in patients treated with UPA was generally low across PsA, radiographic axSpA, and non-radiographic axSpA. In radiographic axSpA, history of uveitis appeared to predispose patients for future uveitis flares, regardless of treatment. Development of uveitis and IBD were generally similar following treatment with upadacitinib or adalimumab in patients with PsA. Longer-term follow-up of the impact of upadacitinib across EMMs in SPA may help clinicians make informed treatment decisions and guide future treatment recommendations to improve patient care. Laura, what are some of your thoughts about these findings?
Yeah, so I think obviously this is a minority of our patients who have related conditions, but I think it's one of those groups that are so important to think about trying to control, obviously their arthritis, but their skin, their inflammatory bowel disease and uveitis, and they're often the ones where we really need to have detailed conversations with other specialties and get input from other people to try and optimize treatment. So I think it's really important for us to have the right data for newer therapies like upadacitinib and think about how that might work well in patients with related conditions. And certainly from my perspective, the first few patients that we put on upadacitinib when we had it kind of brand new and approved were patients who had inflammatory bowel disease as well. And we had some sort of specific requests from our IBD team saying, you know, as patients run out of drug options, we think they'd be a great candidate for UPA. Can you help, because we can't access it yet. So that's often where you can sort of work together with colleagues and access different drugs in different ways. I guess the only key thing we need to think about in terms of efficacy or best data is making sure that patients get the right dose, because we're obviously using the 15 milligram dose. And this data looks good with the 15 milligram dose, but for real efficacy in IBD, typically higher doses are used.
So you point out the important aspect of the teamwork with gastroenterology and, in this context, both ophthalmologist and dermatologist as well with these associated conditions. We know now that since upadacitinib is approved for the treatment of Crohn's and ulcerative colitis, we have reasonable confidence that if a patient has this as associated condition, that this will be helpful. And we also have plenty of data in psoriasis. We have less data about uveitis. And I've seen various case reports suggesting that there might be some benefit for uveitis with the use of upadacitinib, but we don't have any controlled trial data. And so we have to look at registries or look at this kind of indirect evidence to at least to know that we're not likely to cause a flare of uveitis if using upadacitinib. So Laura, you led the GRAPPA group's most recent treatment recommendations effort. And I noticed that you elevated these associated conditions to be considered as importantly as the other usual domains of psoriatic arthritis, like arthritis and axial disease and skin disease and so on. What led to that decision to do this?
Well, so I think, I mean, as I mentioned before, it's definitely a minority of cases. Most patients don't have these multiple conditions, but where they do, it really has to drive your treatment decision, because you're trying to control inflammation across whatever tissues are involved in that individual patient. I think the other, we had always sort of included them before, but they were lumped together with other comorbidities. So we had kind of IBD, uveitis, fibromyalgia, depression, liver disease, all sorts of a kind of mishmash of comorbidities. The other reason we really wanted to separate it out is obviously we have quite good data in these cases. So the data around what biologics do in depression or in liver disease is pretty limited. It's not like these drugs are going to be licensed for that indication. But as you've mentioned, these drugs do have licenses for inflammatory bowel disease. A few have significant data on uveitis, certainly for psoriasis as well. So it's very easy almost to put them into that same treatment algorithm, because you're thinking about mostly similar drugs, and you've got good quality data from RCTs. Not necessarily RCTs of people who have psoriatic arthritis and IBD, but definitely from patients with kind of a general presentation of inflammatory bowel disease. So we felt the quality of evidence was there as well to make quite specific recommendations.
Thanks so much. And you really emphasize the importance of considerations of these conditions. So we're coming to an end here, and we'd like to thank you for joining us for this PsA podcast brought to you by the Immune-Mediated Inflammatory Disease Forum. We really hope you enjoyed and found it useful. If you did, don't forget to subscribe to our channels on YouTube, Spotify, SoundCloud, or wherever you get your podcasts, so that you don't miss any future episodes. If you want to read more about what we've discussed today, visit www.imidforum.com, where you'll find detailed summary slides for today's publication. See you next time.